Coming to question 7 of NEET previous year question discussion series. So to understand this question, we will read from the last line. A diagnosis of Addison's disease was made. What is the cause of hyperpigmentation in this condition? See, this is the reason why in NEET question paper, always you have to read the last line, because the question seems large, and during times of stress during the exam, if you read from the first line, you can definitely miss. So always to have a clear picture of what you are going to read from the question and what you are going to answer from the question, always read from the last line. Because in this question, there is no need to read the first 3 lines, because they are given clearly. A diagnosis of Addison's disease is made. What is the cause of hyperpigmentation in this condition? So I think in the last question we discussed, Addison's is actually cortisol deficiency. If you see the adrenal gland, it is of 2 parts, adrenal cortex, and the inner part is the adrenal medulla. Adrenal cortex, remember the term GFR. Zona glomerulosa, zona fasciculata, zona reticularis. Zona glomerulosa secretes mineralocorticoids. The important mineralocorticoid is aldosterone. Aldosterone is a part of the renin-angiotensin-aldosterone system. We have zona fasciculata. It secretes glucocorticoids. The important glucocorticoid is cortisol. And we have zona reticularis. It secretes sex steroids. We have many among them. And every hormone is associated with a particular disease. Okay. And zona and the medulla of the adrenal cortex secretes epinephrine. Okay, adrenal medulla secretes epinephrine. So Addison's disease is actually problem with the entire adrenal gland, especially adrenal cortex. Okay. So for all hormones, there is a control from the pituitary, ACTH, adrenocorticotropic hormone. So this adrenocorticotropic hormone has to stimulate zona glomerulosa, fasciculata and reticularis. But the catch here is zona ACTH does not have much control over the zona glomerulosa, which means the mineralocorticoid system is not under the control of ACTH. Okay, it is not under the control of ACTH. It is controlled by the renin-angiotensin-aldosterone system. Whereas zona fasciculata and zona reticularis are controlled by ACTH. This is very important when you discuss the pathology in pediatrics about a few diseases like congenital adrenal hyperplasia. We are not discussing that here. So, like in last class we discussed, we have cortisol, aldosterone, sex steroids we are not discussing, and we have epinephrine. So cortisol excess leads to a disease called Cushing's disease. Cortisol deficiency is Addison's disease. Cortisol excess is Cushing's disease. Cortisol deficiency is Addison's disease. Similarly, aldosterone excess is called Conn's syndrome. Aldosterone deficiency is again Addison's. So the thing is, when adrenal gland is destroyed, obviously everything is going to be lost. But since the zona glomerulosa, zona fasciculata and zona reticularis are 3 different parts, the hypersecretion can come differently. And epinephrine excess, you know the disease, pheochromocytoma. Deficiency is right. Okay. So in Addison's, I told you it's a deficiency of cortisol, it's a deficiency of aldosterone. So when cortisol is low, feedback mechanism happens. So I told you ACTH is the one hormone which is secreted from the pituitary, which increases secretion of cortisol normally. So when cortisol becomes low in Addison's, this feedback loop gets stimulated and more ACTH is stimulated. So there is cortisol deficiency in Addison's and there is ACTH excess in Addison's. This adrenocorticotropic hormones breaks into few products. One product is POMC, pro-opiomelanocortin. Remember, melanin is something which gives color to the skin or black color to the skin. So ACTH gives black color to the skin. So that is actually the question. What is the cause of hyperpigmentation in Addison's disease? Is due to excess ACTH, which produces pro-opiomelanocortin, which gives us color to the skin. Okay, we'll read the question again so we can discuss few other points. A 40-year-old man with history of pulmonary tuberculosis 15 years back, who had completed anti-tubercular therapy, now presents with severe fatigue. On evaluation, he was found to have severe hyponatremia, 115 milliequivalents, and his random blood sugar was 57. Physician noted hyperpigmentation of skin. See, remember in Addison's, I told you we have two hormones which are deficient: glucocorticoid deficiency or cortisol deficiency, and the other one is aldosterone deficiency or mineralocorticoid deficiency. Glucocorticoid or cortisol is basically the stress hormone. Okay, so the symptoms of glucocorticoid deficiency mainly is fatigue, mental changes, emotional lability. Mineralocorticoid, if you remember basic physiology, the function of aldosterone or mineralocorticoid is to retain sodium and water in the body. And to excrete potassium. Okay, so when there is deficiency of mineralocorticoid, the body cannot preserve sodium, it cannot preserve water, so they will go for hypotension. The body cannot conserve sodium because ENaC channels are stimulated by aldosterone. When ENaC is not stimulated, sodium is not reabsorbed from the distal convoluted tubules of the kidney. So they go for hyponatremia. Potassium is excreted by aldosterone. When that is not there, there will be hyperkalemia. And another important function of cortisol, like in last question we discussed, the function of growth hormone, the counter-regulatory hormones. There are 5 counter-regulatory hormones. One among them is cortisol, is to increase glucose. So when there is glucocorticoid deficiency, there will be hypoglycemia. So see, in this question, we have a few keywords. There is fatigue, which is a symptom of glucocorticoid deficiency. There is hypoglycemia in this patient. That is a feature of glucocorticoid deficiency. There is hyponatremia, severe hyponatremia, which is a symptom of mineralocorticoid deficiency. So even if they didn't give the wording like Addison's disease, if a question has been framed like what's the diagnosis in this case, you can tell it is Addison's. Actually, I combined 2 questions and made it into a single question. There were 2 questions on Addison's. One was a diagnosis of Addison's and another one was the hormone responsible for hyperpigmentation. 2 questions came in NEET 2025 from this one topic alone. And sodium, there are many questions there. Just one important point about hyponatremia. Only the normal value of sodium in our body is 136 to 146 milliequivalents per liter. When the sodium is less than 136 milliequivalents per liter, it is called hyponatremia. There are 3 questions on hyponatremia in NEET 2025. So we can take some time to discuss hyponatremia also. So it is classified as mild, moderate, severe, like 130 to 135 milliequivalents per liter in our body. We called it as mild hyponatremia. When the value is between maybe 120 to 130, it is moderate. The textbook references vary. Some books say it is 125. When it is less than 120, it is definitely severe hyponatremia. Severe hyponatremia is one indication for giving 3% saline or hypertonic saline. The normal saline which we commonly use in our ward is 0.9% saline, also called as normal saline. 3% saline is called hypertonic saline. We'll discuss about this in the next question. So in this case they have given the sodium was 15 milliequivalents per liter. So it is severe hyponatremia. A very important take home, there are 2 hormone deficiencies or 2 endocrine disorders which cause hyponatremia. One is hypothyroidism and the other one is Addison's disease. Okay, if any question comes with the clue hyponatremia and it's an endocrinology question, please remember 2 diseases, 2 hormonal diseases or 2 endocrine diseases which cause hyponatremia or hypothyroidism and Addison's disease. Thank you.